Oh, we got fireflies there. We
I'll
have some
figure
note
that
taking.
out.
I will deny that.
Yeah, a couple of them. Should we make an announcement, do you think?
No, we could.
Hi,
Colleen,
everyone. We're just going
are
to
you
give
able,
it 2 minutes while people log in.
Colleen, are you able to hear me okay?
Yes.
Yeah, my video won't work, so my apologies. I just want to make
Oh,
sure.
we
Worries.
can hear you, Kelly. Thank you.
Good morning, everyone.
Hello, good morning.
How are you?
Good, how are you?
Very
Good.
good.
Thank you.
Okay, looks like everyone's in, and I will continue to let everyone else in. So,
All right. Thanks, Cynthia. All right. Well, good morning, everybody. Welcome to our regulatory roundup meeting. Glad to have you all here today. As always, we're going to start with welcomes and introductions. Do we have any new members on today? If so, feel free to unmute yourself and introduce yourself to all of us. Any new members?
Sarah raised.
Yep. My name is Sarah Daigle Demers. I am the director for the Plymouth Assistive Care Office of Bayada Home Healthcare. This is my first meeting with you guys, so thank you for inviting.
Great. Glad to have you. Anyone else?
I'll second that. I'm Marissa from Bayada Home Healthcare up here in Beverly. Thank you for having us today.
Wonderful. Great.
Welcome.
Thanks. Alrighty, so as always, we usually start our meetings talking about any recent surveys and audit activity. For those of you that are new, I just want to let you know that this is a very informal meeting. Feel free to, unmute yourself, ask questions. This is your meeting and we want to gear it towards your needs. And so feel free to unmute yourself and ask questions at any point. Do we have any of our members on today that have had any recent DPH surveys or any surveys with accrediting organizations? If so, feel free to unmute if you'd be willing to share your experience. It's always so helpful.
Hi, Kim.
Oh, hi, Mary.
We
We were
had,
wondering if you were going to be on. Great.
yeah, I am here. We actually got a double whammy.
Yeah.
Joint Commission showed up on December 3rd at the hospital, but there was no home care auditors. She showed up on Thursday. So we had a 2-day survey with Joint Commission, but Friday morning when I was sitting with Joint Commission, 3 DPH surveys showed up at the door also. So we had both at once. It was great. But it's over and done with now, right? So
Exactly.
we did very well. DPH, they were not very nice. We got 3 women and they were, it seemed like they were almost angry that they had to be there. It took a while for them to even like speak to us kindly. So,
Really?
yeah, it was very strange. I've never had a survey like that.
Yeah.
There were 3 of them. They wanted to do 7 visits that first day. They show up, they
Yep.
want the visits, they want to leave.
Oh.
We could only get them 6 because we already had a whole bunch of visits the day before with Joint Commission. So they did the 6 visits that day and came back and reviewed. They did 7 visits, 5 DC charts, and 5 active charts also. They wanted to see a slew of policies. They looked at our miss visit guideline because we don't have a policy, but we have a guideline, timely documentation, patient assessment policy, um, a policy on completing documentation and accurate record keeping policy, the org chart, the start of care folder. So we gave them everything and they kept asking questions. So we were like, oh, geez, we're really going to get nailed here. And then we had to show them our time log reports because if we're on NetSmart, so if you open it up and add something or change anything, it changes the date stamp. So it looks like the documentation was late, but it's not. So we had to pull that for all the patients they went to see. Because it looked like we were late. It looked like we were like a week late
Yeah.
on some of them. So that was straightened out. We went over our EOP. That was fine. So then they came back. One came back Tuesday, did the visit, finished reviewing the other charts, and asked a whole bunch of more questions. But then we ended up with no deficiencies. So, right. So I think we were able to justify everything that she thought was wrong. So, but with Joint Commission, they only made 3 visits. They looked at almost every policy we have. They did the EOP. They went over whatever we did for, what we did with the clinicians. They wanted to see, we have an evade training. They wanted to see that. They also looked at a bunch of discharges, and they wanted to see a discharge with a transfer to hospice and a transfer to the hospital.
Oh,
So
wow.
we showed them that. Yeah. I thought that was and she looked at all our infection control policies. She thought they were excellent. She said the clinicians did a great job with infection control in the field. She looked at QAPI. DPH did not look at QAPI, didn't ask about QAPI, nothing. She looked at HR records for the clinicians she went out on visits with. DPH did not look at any HR records. She wanted to see a patient that was on remote patient monitoring, because we have that, so we showed her that. And the only thing we got cited on with Joint Commission, we only got 1 finding. There were 3 things that fell under the 1 finding. It was one med was put in the system, and it just said Marilex packet. It didn't have a dose or a route. And then a PT chart had some modalities in their summary. It said something about compression stockings, but it wasn't on the orders. So she, even though it was on the plan of care, she didn't like it that it wasn't in the orders. And then the third thing was, this was just, she happened to look at this chart. Somebody took a verbal order. They wrote a clinical note. The way our system is, they put the clinical note in, but they didn't go in and put the frequency in. So we had no frequency for that 1 visit. So they all fell under 1, and it wasn't major. It wasn't anything. So we have very little to do for this, because most of it was just a one-off. So it's just some education with the clinicians. So we did very well. So the hospital was very happy with us. So.
Yeah. Great job. It sounds like your DPH survey was pretty intense compared to what we've been hearing.
Yeah, I couldn't believe 3 of them showed up, and they just kept at us all day on that Friday. And I'm like, oh my goodness, are you ever going to go home? And they finally left at like 4:30. And then Tuesday I wasn't there. I was on vacation. I was in Vegas. I was like, good luck to you. So
For you needed it after
but it
all
was
of that.
they called me twice, but it was just one of them, and so we
Can
were
I
happy.
ask for the visits? What disciplines did they go out on visits? Were they let you choose the visits, I'm
They
assuming?
let us choose the visits, which was great.
Yeah.
They went out with Joint Commission went out with nursing and PT, and DPH did the same. I don't think any OT visits were made. Yeah, nursing and PT. So
Great. Wonderful.
we don't have home health aides, so that was,
Okay.
So.
Great. Well,
Hey,
Mary,
it's
thanks for
Hi,
sharing.
Kathy. Hi. Am I on? Oh, Kathy from
You are.
Berkshire.
We can hear you, Kathy. Hi.
Oh, great.
I thought
When-
you retired.
you
I
know,
know.
isn't this what retirement looks like? I
They got you
I
back.
thought to say I am remote in Florida, but Preeti couldn't attend today. When was your DPH due?
We were right on time.
Ah, okay.
Right.
we're-
And I said to them, I said, I'm glad you came, and we, can get this done. I said, I didn't think you'd be here this right on time. And she goes, we're not behind. Like, they were just so angry. I'm
Wow.
like, oh, okay.
Were they all RNs? Were they
Yes.
all RNs? Yeah.
Mary, I
Uh,
think DPH came to you though, because you're joint commission and there's a certain percentage that DPH has to check joint commission. So
Yeah,
they weren't doing you like they do another agency who's not with an accrediting body. They're there to check joint commission and they have to write a different kind of report to the government. So
Oh, okay.
that's probably why they were mad, because they have to be thorough, look at everything, and then
Yeah.
compare what joint commission had.
Oh,
I-
yeah. There's just no need to be like that. I mean, we were more than, pleasant and helpful in getting them everything, and it just was there was no need for that.
Yeah.
I don't,
it's too bad.
Yeah, no,
yeah.
I had heard from others that they were running behind, so that's why we're doing
Oh,
January.
okay. Yeah. Oh,
You're doing
Anyone
in
else?
January, did you say?
what?
Did you say you were doing
we're-
January,
yeah.
Kathy?
Yeah, we're doing now. Yeah.
I actually had a
else?
survey in October
Karen, yeah,
and similar, we're a small hospice, so no, four of them, it was four of them. Yep, four, it was four people that came in and same, they were very, it was for hospice and I remember being shocked to see them because I didn't think they were doing surveys, but apparently they were for hospice. And one of the surveyors was and I saw this on the last regulatory roundup, I think, was stuck on the 48 hours to complete the assessment. And I argued with her because I told her if it can't be completely completed, because I mean, the other clinicians have the 5 days to see the patient. So our documentation system, if we need to send it back, even if it was done and completed and signed that first day, if it needs to go back to the clinician for correction, it's going to timestamp it a different day.
Oh,
right.
yeah.
Same thing goes through all the other and any other documentation. So she's like, well, then how do we? I'm like, I can't change how that works, but I can tell you that it was completed, and there's no way we're going to have it completed, have it reviewed, sent back, and corrected in 48 hours.
Right.
So she actually didn't. So they ended up citing us on just timely documentation. She didn't cite me on the 48-hour thing, but they definitely cited us on timely documentation. But the 48-hour, from my interpretation of the regs, is the nurse has 2 days to go see the patient after the consent has been signed, or once they've signed on to hospice. We do it the nurse usually goes out that same day, or the next day. If like the consents were signed like late at night and we didn't see them till the next morning. But she was like a dog with a bone, wouldn't let go of it. I'm like, it's impossible. I cannot, even if it was completed the same day, it's not going to show it because of the timestamp.
Right.
Very
Yeah, Karen,
frustrating.
and I think at our last regulatory roundup, I'm not sure if you had attended, we had actually taken some of the information that you had given Colleen and I about your survey, and that was what we were speaking to. And I think we heard from another hospice agency too, that they were focusing in on that area also, the 48 hours. So, yeah.
And then also the volunteer
Yep.
hours. And again, we told them, it's after COVID, it's really hard to get anybody in there that has time, and it's usually, your retired people who don't want to go into the nursing homes and are worried about getting sick. And we also got the missed visits and the home health aid documentation. Most of our aides still do paper for their ADLs for documentation, and they submit it every week. However, the home health aide signed on the wrong day, and they
Oh.
cited us for that.
Oh,
Mm.
yeah. Yeah, it's a challenge when you get aides that are still on paper. Certainly just adds another element to it. Yeah, great. Thanks for sharing, Karen. Anyone else that's on? No? So we did have one of the members reach out to us that had a DPH survey, Tola. I don't know, Tola, if you're on, and had given a summary of what their experience was. So, we did include this on the slide. So they also had 3 surveyors on site. Looks like they were there for about 2.5 days, half a day on a Friday, skipped Monday, full day on Tuesday, and concluded on a Wednesday. Similar areas looking at the emergency preparedness, staff education, risk assessment, missed visits. We are hearing that throughout, really hearing that throughout. So certainly make sure again that you're documenting the reason behind the missed visits, that you're attempting to make up those missed visits within the week if possible. And again, if you're out of frequency, make sure that you're documenting notification to the physician. Again, abuse reporting, staff abuse education. It sounds like they did look at their QAPI program. I'm not sure on the record reviews. I think Colleen, she had sent this to you, so 3 patient charts against 3 disciplines and 3 employee personnel files. I'm not sure how many visits they made to this agency. And again, they did look at the verification of licenses, certification, and the nurse aid registry check. So if Tola's not on,
I
don't
think
have
she
any
said it was,
indication.
I did this. I think she said it was 3 visits.
Just 3 visits.
Yeah.
Okay, great. Wonderful. All right then. So it sounds like pretty much in summary, they're pretty much on time and focusing in on the areas that we're hearing throughout. So all righty, we're going to move on to Mass Health. And Colleen's going to give you an update on our Mass Health stakeholders meeting that occurred yesterday.
Thank you.
You're welcome.
So yesterday, Mass Health had a meeting. There were a lot of people there. Can you go back to the other slide, Kim?
Oh, I'm so sorry. You know what I did? Sorry about that.
That's all right. No problem. So just to give you some updates, they told us that the rates for home health services as well as the home health agency regulation are going to be coming out with changes. So the proposal should be out by March, early March, mid-March, they said. They couldn't give us a date. And then they're expecting the public hearing to be in April. And then they anticipate these regulations and rates to be effective on August 1st of this year. Also in that, they mentioned that they're having a new program. They're going to have a home health agency value-based purchasing service. I shouldn't say program, it's a service. And they're also anticipating that in the same timeframes as the regulation. And basically, the home health agency regulation, most of those changes are going to be because of the value-based purchasing services. There were some questions on the meeting about, they wanted more information about value-based purchasing, and Mass Health said that they're going to tell us more details at a later date. But basically, it's going to be a specific type of patient, a patient who has a lot of comprehensive needs at least 4 visits a day, and med administration visits. And I think they have to anticipate being on service for about 26 weeks. They have to have had 2 hospitalizations in the past year, or 1 hospitalization and a couple of ER visits. So, I don't think it's a huge population, although they didn't say exactly how many patients it was, but more to come on that, and we will definitely keep you updated. So the request for application, you actually have to apply if you're interested in providing the service. They said that information is going to come out again in March. So we will definitely keep you updated about that. Next slide. They mentioned electronic visit verification, that we're in compliance checkpoint 2. So it's from last July through March 31st. At this point, agencies have to have a 40% auto-verified visit compliance. They told us people were doing fabulous, very well, more than 40%. But there's a few agencies that are either agencies are really struggling, most agencies are doing quite well. And if you're not sure, you can go on to Mass Health, the EVV website under the job aids. And I put the link here, and Cynthia, she will share these slides with you. You can go directly to see what your compliance rate is. Mass Health also said before the March 31st, they're going to actually outreach to those providers who have very high incomplete auto verify visits. And right now as well, they're having soft edits in the remittance advice. So if your EVV isn't matching your billing and all of that, you'll have, it's not denied, but they want people to be able to fix these in advance. So you're going to see that in your remittance advice. Next slide. This was not mentioned in the stakeholders meeting, but since we're talking about EVV, I put the slide here. Agencies have been asking about, for their compliance especially, if your system is down for 2 days and you're seeing 400 or 500 Mass Health patients a day, it's a huge amount of visits. And so they're concerned, like, what is the process? And more so, they're asking, in an emergency situation, what do we do? And this came about because a couple of these agencies, I think it was actually before COVID, they had a cyber attack, ransomware, and they were without their software system for over a month. And I remember this because I remember helping them with waivers with CMS. So they're thinking about that, and they want, what is the process? So I emailed Mass Health, and this is what they told me. Unfortunately, and I'll go over this slide with you, but they did not address my long-term emergency if an agency is out for weeks, months. So we will continue to advocate for our members for that because we think it's important as well. So I asked about any proactive notice that we have to give Mass Health if your system's down. They said it's not required. But it would be helpful for if you really have a prolonged outage. And I strongly recommend that you reach out to them if that happens to you so they can jot that down for your compliance. If you're using Alt EVV system, you must submit your visits once you have restoration of your software. And your outages are not, it's an event level exception at that point, they said. Manual entries are allowed for Alt EVV, but they will not show as auto verify, which is why the agency is worried about it. And Sandata users may continue using the offline mode, and the visits automatically restore once your computer's up. And there are no special reconciliations requirement ensuring all visits are submitted. So no special paperwork or anything like that. Next slide. They shared these important reminders. They mentioned them last month as well. So I'm assuming people are still not in compliance. Fiscal soundness, it's past due. This was due early last 2025. And the cost reports are still waiting for. What they brought to our attention is for the cost reports, you have to do your nursing service cost report, your NSR, your financial statements, and your Medicare cost reports. If you didn't do all 3 of those, it's not going to show that you submitted. If you're a home health agency who also does continuous skilled nursing service, that block nursing, you have to do 2 separate cost reports. So maybe that's some of the delay. And then we do have providers, and one reached out to me last month. They don't have enough Mass Health patients, so they're in an exemption. But you still have to request an exemption, use the form, and then it has to be approved by CHIA. Just because you sent it in doesn't mean they approved it. So that might be some of the delay. And the first bullet on this slide, they mentioned, this came out in December. There's a Home Health Bulletin 95. It talks about a 14-day notice requirement. So if, I guess there's been a lot of agencies who have been delinquent when it comes to change of address. You had change of corporate structure, a change of ownership, doing business as, that type of thing. you have to have 14 days is required for you to be a Mass Health provider. So I just wanted to bring that to your attention. And again, the Bulletin 95 link is there. Next slide. They brought this up, OneCare. There's been a lot of issues with patients, and this is probably more so on the home care side, although some of the certified agencies have seen it as well. For the duals, CMS would allow, chore service, homemaking, all of that for the OneCare folks, but that was a demonstration project and that ended. So Mass Health did submit for a waiver for these folks, the 1115 waiver. They did that back in the fall of 2024, and it's still pending approval. So as of January 1st, certain home care-based services, community services, are no longer authorized for OneCare patients. So patients were scrambling, agencies were scrambling, trying to figure out where are they going to get these homemakers and other services. So the plans actually had to notify the members. They had to identify if there are any other alternative covered services. And some of them actually received some flexible benefits because they really needed those services. So if you have any questions about that, Mass Health advised that you actually call your plan contract representative yourself. But if there are any other questions, Henry McGill from mass.gov actually was nice enough to give his email for patients who are still having issues with this. So I wanted to bring that to your attention because Mass Health talked about this for quite a bit. They also mentioned the face-to-face with telehealth. They are following the federal guidelines. It is only permitted through January 30th. And they said they continue to monitor it. We have been monitoring it as well. We've gone to CMS. Jake has talked to legislators about it, and we're hoping, I think the issue is it being permanent. We're hoping for at least a 2 or 3 year extension if they can't do it permanent now because of finances and whatnot. So more to come on that, but we'll definitely keep you posted because we know that really affects everyone. Next slide. Well, that's you, Kim.
I'm just going to see if I can hide my thumbnail so I can read my slide. Perfect. So I'm going to talk to you today about just give you an overall view of the advancing interoperability and improving prior auth processes. So in January 2024, CMS issued this advancing interoperability and improving prior auth processes final rule. The rule really is looking at improving the exchange of health information, looking at transparency, and really looking to streamline some of the prior auth processes so that there are no delays in provision of care to patients. So prior to January 1st, the prior auth timeframes for standard requests were nursing. It had to be adjudicated within 14 days of the date that the prior auth was received. DME was within 15 days, and all other services were within 21 days. So effective January 1st, Mass Health will be adjudicating all services within 7 days from the date that the prior auth request is received, excluding pharmacy drugs. So this is a significant decrease in the time, which is a good thing to prevent, delay in our patients receiving services. In regards to expedited prior auth requests, the time frame for those also have changed, but I do draw your attention to what I have bulleted here, and I also have the Home Health Bulletin 93 underneath that provides a lot more information to you. The home health expedited requests for your patients that are discharging from post-acute discharge to home health agencies, those continue to be processed within 1 business day. So there has been no change to that process. For the other service lines, the expedited PA referrals will be adjudicated within 72 hours. One thing to be aware of is if the prior auth request is submitted and the clinical criteria for it to be expedited is not determined to meet eligibility, then it will be flipped to a standard request, and then you will be looking at that 7-day time frame. In regards to deferrals, there also has been a change in that time frame. So when a prior auth request is deferred, so if it is paused due to incomplete documentation, something's missing, that review time frame now is extended to 14 days from the deferral date. Prior to January 1st, that deferral time frame was 21 days. So, what's really important to remember is if you have a deferral, that time frame is shortened now to get that information in. Mass Health did stress during their webinar that there's been no changes to what's required to submit for your prior auths, no changes at all with the required documentation. It's just the timeframes that have been shortened again to prevent some delay in providing treatment to our patients. They have updated both the provider online service center and the long-term service center portals to include these shortened timeframes. The Mass Health updated the POSC to allow when these referrals are put in, when these authorization requests are put in, for your standard requests to indicate that you want it expedited. Again, if it meets the clinical criteria for expedited request. And then in regards to transparency, so annually, and it will be starting March 31st of this year, Mass Health is actually going to post the metrics on mass.gov. So you will be able to go on and really look at the percentage of standard and expedited prior auths that have been approved, that have been denied, be able to actually see what was the time frame from submission of requests to approvals, and really all items and services that request and require prior authorization. So this is actually going to be interesting to go in and see really what are these percentages. And again, the first submission of this will be March of this year, and then it will be updated annually on mass.gov. I've given you links here to all of this information. Again, this was just really a high overview of the presentation that Mass Health did do back in December for all of us. And again, these links will take you directly to the detailed bulletins onto mass.gov if you have any other further information, or your those that are submitting authorizations for your agencies need that. Those references, they're here available for you. Does anybody have any questions about that? No? Okay, then. So we have a couple of FYIs and reminders to you. So just so you're all aware, on December 18th, so CMS did release the OASIS E2 guidance manual. And again, I did put the link here for you to save. Again, remember the OASIS E2 goes into effect April 1st, which is a change from the normal January 1st timeframe. Not a lot of changes to OASIS E2, some removal and some additions to time points for some areas being added in, but not significant changes. But you want to be aware of them, and you want to begin, educating your staff in regards to these changes that are coming. And then several of you have reached out to us. We are aware that the ABN notice expires January 31st of this year. I did go on this morning to see if there is an updated form. There's nothing updated as of this date. Remember, the guidance from CMS is that you can continue to use this form until a new one is available to us. So we will be checking this, and certainly communication will come out to all of you when this new form with the new expiration date has been released onto CMS's site. Just a reminder to those of you that have Mass Health dually eligible patients, just a reminder that they do need a newly completed and signed ABN form every 12 months. Or certainly more frequently if something changes. Most of these patients, everything is pretty much status quo, and they're long-term patients. Many agencies have their patients sign it on January 1st so that they don't have to, it's easier to remember to have these forms signed the beginning of the year. So just a reminder, You do want to check to ensure if you do have these patients on service that you do have updated ABN forms in their chart. And then, as Colleen already spoke to, the telehealth flexibilities only extended through January 30th. We again will keep you updated on anything that comes out. Hopefully, again, it will, if it's not made permanent, hopefully it will at least extend for another couple of years instead of going through these periods of every 3 to 6 months waiting to see if it's going to be extended. So we expect to hear something soon on that, and we'll certainly keep you updated on that.
Kim, I had thought we didn't need to renew the ABN every year unless services changed. I thought they made that change with the ABN. I'll have to relook at it. Yeah.
I believe, and I could be wrong, and I can double check it too, that
Yeah.
and Colleen and I were discussing this, that if nothing has changed, you still need to, at a minimum, have a newly signed form every 12 months. But we can double check that and just to make sure that we're correct on that.
Great, thank you.
Yeah, no problem. The next slides that I have for you. So I wanted to bring to your attention, I don't know how many of you are aware of this resource that's available to you. So we thought this would be a great opportunity just to introduce it to you and show you what's available. Both Colleen and I sit on the Provider Outreach Education Advisory Council for NGS. And we're really looking at the education that's available to members and the resources that are available. And they've updated some education on Medicare University, which actually is really, I think it's excellent. I've taken the courses myself and just felt that you might find it useful if you're not aware that this resource exists. So I'm just going to show you a couple of screenshots. And, if down the road you feel like you would want a more detailed tutorial or even a hands-on, we can run through it. Let us know, again, because I do think there's a lot of resources that potentially you're not aware of that do exist not only through Medicare University, but also on the NGS site. So when you log on to NGS, when you pull up their website, you will see this. You can access the NGS Medicare site for Medicare University without having an account. So on this left-hand side, you put Home Health and Hospice, Massachusetts, and it will bring you to this screen. So in this screenshot, today we're going to talk just briefly about the Medicare University, but I do draw your attention to the other resources here. There are manuals and guides. Under resources, you have detailed resources in regards to home health documentation requirements, some audit tools. It really is a very comprehensive site. And I bring it to your attention because I'm not sure how many of you really have accessed it or have looked at it recently. But I do recommend, if you haven't, just hop on when you have a spare 15 minutes or so and take a peek and see what's available to you. In regards to Medicare University, when you come on and you pull the drop down for the education and you click on Medicare University, it will bring you to this screen. This screen gives you a little bit of history as far as what's available. It also provides you with the ability to set up an account for Medicare University and create your own login. I've actually provided these links for you. And again, you'll have the slide deck sent to you afterwards so you have it. But again, it's online learning. You can do it at any point. They really are beefing up home health and hospice education. So I would encourage any of you, if you have the ability to go on and take any of these they're very, very short educational opportunities. I would appreciate the feedback because we have these meetings quarterly and we do go back and say, the members found this really helpful, so that they can continue to develop these educational opportunities for you. These are the links here. And I just wanted to quickly show you what it looks like. So when you establish an account, you create an account, every time you go on, you'll come to this welcome page. And up along the top is where you can see the home page and the learning library. The learning library is what you'll click on, and it will bring you to a page that looks like this. You can actually type in the search bar if you're looking for things that relate just strictly to home health or hospice, and it will pull up the available learning opportunities for you. These are the new items that have recently been added. And as I said, I think they're really great. They're great. You can use them for if you have new clinicians that are new to home care. This particular one on home health billing in the period of claim goes into detailed education about PDGM and all of the components of billing, the 30-day billing. It's really very good. The hospice ones, if you're new to hospice, talks about eligibility, the election guidelines. There's another one that doesn't show you on the screen, but there's a detailed one on the different levels of, hospice care. Again, they're short little snippets. I really highly recommend them. And again, they will be adding more to it. But really recommend if you can pop on and take it and give us your feedback, we really would appreciate it because then we will take that back to the advisory council. Does anybody have any questions about this, or just curious if any of you have really accessed Medicare University, find it helpful, not helpful? Feel free to unmute and tell us your experience.
Yeah, I've used it, Kim, and years back or whatever. I think their homebound explanations are really good for staff. I find it plain English. Yeah, I recommend it highly as well. Yeah.
Yeah, great, thanks. Yeah. As I said, it really, I was on last night just going through some of the modules on NGS, not specific to Medicare University. And I think it's probably underutilized. Again, for new staff, it really is, it really is quite good. So just bringing it to your attention in case it's a resource that you're unaware of, or perhaps you had gone on Medicare University in the past and you really didn't find it very helpful. They are revamping the home care and hospice. So I just wanted to bring it to your attention. All right, Colleen.
Yeah, Kim, the reason I shut my video off is I was looking for the ABN. So I couldn't actually find it in the how to fill out the form instructions. But after Kathy said that, that jogged something in my memory. So I didn't find it in regulations. I will look, but on a legal site, it did say that it did change to, you don't have to have it signed yearly, as long as there are no changes. So if it stays the same year after year, it does appear that you do not have to have the patient sign it again. But I will definitely back that up with citation from CMS. I've talked to folks about this before, and we have a few agencies involved. So the Executive Office of Health and Human Services, this is both a state and a federal program. They are working, it's called the Career Ladder, CLP, and they want home health aides and continuous nurse staff to become LPNs. So some agencies of ours are already involved. What this program entitles, it gives the student tuition support, coaching, weekly wage stipends. The agencies would adjust their staff to part-time during that LPN training. And then these participants, once they get their license, they have to commit to 2 years of employment with you, with your agency. So as I said, 2 of our agencies have taken advantage of it. Mass Health actually contacted us in Home Care Alliance this week to tell us that there's still money available. There's a lot of not at the aides in the nursing homes, they're taking advantage of it, and Mass Senior Care, those members. So they reached out to us again to bring it to home health agencies' attention again. While there's money there, if you're interested, you can call, email, and there's more information, Mizorowski at masssenior.org for more information if you're interested. Next slide.
Yep. Oh. Great. Oh, we have the question of the month. So as you know, many of you reach out to us throughout the month and put questions out to Colleen and I. We appreciate that, and hopefully you find it helpful. We did see a trend over the past month, just looking again for some clarification on the final rule for the face-to-face regulatory changes. So we thought that we would just review it for all of you. In short, just remember that the practitioner that completes the face-to-face encounter, it does not need to be the certifying provider. This really flexibility, the real change was really in our community referrals, and this was a good change, right? So that means that the certifying physician does not need to be the practitioner who performed the face-to-face encounter. But again, that encounter needs to support the reason that the patient is receiving home health services. So for those community referrals, again, we'll use the example, patient goes and sees their oncologist. The oncologist saw the patient within the appropriate time frame. A referral is placed by the PCP to the agency for the patient to receive home care services. That face-to-face encounter that was performed by the oncologist can be utilized. So no longer do we have to try to get the patient in to be seen by the PCP within that 30 days. This was a very good change for us. I think everybody feels the same way, but I think it did add a little bit of confusion. No changes, but your patients that are discharging out of your SNFs and acute care hospital, you can use that discharge information. Again, you want to make sure that it is appropriate and it supports the reason that the patient's receiving home health services. But again, just to clarify, now, as we've used before, I think Colleen has used this before, if they go and see their, eye doctor, that encounter certainly is not going to be supportive of why the patient's receiving home health services. So again, you want to make sure that it meets all the other requirements. But I hope this clarifies this. Again, I think there was just a little bit of confusion because we did receive a fair amount of questions over the past month. Does anybody have any questions on that? Need any further clarification of it? Okay, great. And now we have a couple questions here for discussion. So these are questions that were sent in to both Colleen and I, or one or the other, and we're putting it out to you to ask for your input. So one of the agencies reached out and was wondering if any agencies allow LPNs to reconstitute a subcutaneous injection. So we're not sure. We're putting it out there. Do any of you allow your LPNs to do this? If so, feel free to unmute yourself.
In what
Nobody?
setting?
I'm sorry, what was that?
Oh, in what setting?
I believe it was the home health setting. Colleen, I think this question
Yeah, it
came
was.
to you. Yep.
Yeah, it's home health. It went out on the listserv, and no one answered the question.
Yeah.
So that's why I put it on. I didn't know what the answer was.
Yeah.
It's been a while, but I went from being an LPN to an RN, and when I was an LPN, I remember not being allowed to.
Okay.
But once I was an RN, I was allowed to, but I don't know if maybe policy changed, but that's what I remember.
Oh, thank you.
Anyone else? Right. And then the second question that we had come to us was from an agency where an occupational therapist was in the role of a manager. And this agency reached out to us to see if any agencies allow their OTs to take verbal orders for medications. And if so, do you have a process where the nurse is actually signing off on those orders? Again, this agency, the OT was in a managerial position and they were struggling with, was the OT able to take that verbal order? And if so, is there a process in place for the nurse to review that and sign off on it? So again, I think we put this question out there, didn't have any answers back. So we thought that we would bring it to this meeting to see how your agencies are managing this situation, and if so, if you'd be willing to share this with us. Anyone? No. All right, then, Colleen, I guess that's why we didn't have any answers to our questions. And then our next topic is, so we are going to have an in-person spring quality conference, which we're really excited about. We haven't set the date yet. We're probably looking for the time frame of towards the middle to the end of May. And we're just in the process now of meeting Colleen, myself, and Cynthia together to talk about our agenda. And we thought we would bring it to this meeting to ask, what would you like to hear? What would you like to see? Is there anything that you feel, we haven't really covered in regulatory roundup? I know we cover so much, but, any topics that would really be a draw for you for this quality conference. So it's really an open discussion right now. We're having a meeting again tomorrow to really work on the agenda. We are reaching out to CMS to come and speak about a topic. But if you want to unmute yourself and kind of give us some ideas that you might want. If you don't have anything off the top of your head now, you can always email Colleen or myself if you finish this meeting and say, oh, shoot, this is something we'd really like to hear about. But I'll stop talking and see if anyone has any areas that they would like perhaps for us to touch upon at the quality conference.
Hi, Kim. Hi, Colleen. Yeah,
Ricardo.
thanks so much for holding these for us. It is important for us. We use the shared experiences with DPH surveys very much here. So anytime we can get that sharing and that communication, it is super, super helpful, because it seems that each year, the focus changes a little bit. So if you're just setting your DPH survey to meet, the same standards as your previous one, you're gonna fall flat on your face. So,
Right.
so these are really nice in that they keep us, current, up to date with what's truly going on in real time with DPH. So that is super, super helpful for us. Obviously, all the clarifications on the rules and regs that come down on a constant basis is super important as well. So I guess more of the same. I hate to say that, but I think you're doing a great job.
Oh, thank you, Ricardo.
Ricardo.
We
Thanks.
we were thinking about having someone talk actually specifically about survey. But we didn't know, and I'm glad you mentioned that, if that would be, people wouldn't be interested in it. But Ricardo, it sounds like you would be interested if we could get a speaker on that. Yeah.
Yeah, I think it's you can never be prepared enough. And like I said, they change every so often. So I really feel that this sharing of information that goes on in this group is what makes the difference for us to be in tune with the current mode of survey.
Thank you.
Great. Holly, did you unmute? Did you want to share something?
Thank you, Kim. Thank you. Yes, Ricardo, that's a great overview of how supportive and helpful this whole group is. Thank you very much. I second that. I wanted to say what I think would be beneficial is for the conference is it would be helpful. There are so many quality regulations and so many quality initiatives that we try to implement, and things always changing, always evolving. We often struggle with staff engagement in the changes. So I think it would be beneficial if anybody has any ideas on how best practices on how to get staff engaged with some of the quality initiatives. Thank
Great.
you.
Great.
Good one.
Holly. It's a great idea.
Thank you.
Yeah.
I-
Anyone else?
Sure, I would say value-based purchasing, interpreting IPRs or the TPS scores.
Yeah.
It's changing. Our survey is going to be changing. Our HCAP survey is going to be changing, and putting some focus on interpreting. That one question drives me crazy, that the patient is now going to be asked, did the staff care about you? Right.
Right.
So I think it would be helpful for folks to understand how to use that information.
Great.
Good one.
Yeah, I think, when you're looking at those reports, to your point, what does it mean, right? At the end of the day, how do you move your scores, and And again, as you said, as Holly spoke to, just staff engagement through all these changes. So, again, we don't, I know there's so much information, and we talked about value-based purchasing, Colleen, Cynthia, and myself. And so, thank you for bringing that up, because we don't want to inundate you with information that we feel you're getting from so many other sources. But I agree with you. I think really being able to look at, what's changing in value-based purchasing, and what does it mean, and what's changing with the HCAP surveys, and how does it all transcend, right? So I think that's a great idea. Perfect. Anybody else?
Kim, why don't we do the poll, ask Cynthia to do the poll, but then we'll go, there's a question in the chat, but I think Cynthia
great.
gonna have to get off. Cynthia?
Oh,
Hi there.
so
Okay, I'm gonna find the poll. And this is it, the January 2026 regular thing. And it's it's three, just a choice of three answers. I'm gonna launch it. And there you go.
yeah, so this is Barbara Citarella is interested in doing the emergency prep tabletop exercise, and we're just reaching out to see what your interest would be in participating in this. So if you could just complete this poll, that would be lovely.
And it totally makes sense that we would need more details. So, which is kind of what we thought, but okay.
We'll be looking. Everybody take it?
Think. Oh, then we have 21 and 25. It's looking at, but that includes us. So I think.
So
I think
just
we're good.
quickly, not to give you the exact details of the tabletop, but just basically what it is, Barbara comes up with a scenario of an emergency situation, and the folks in the room break up into different sections, and they analyze the process of what you do during the emergency. And this meets, and then you go over the whole plan, and then after she gives you all the information, so you can take this back to your agency. So you'd be able to do it with your agency yourselves. And then that would meet your emergency preparedness for the tabletop. So I don't know what she's going to pick this year. She's done it 2 years in a row. The folks who go seem to really like it. But since we did it 2 years in a row now, we didn't know if people would be interested. So that's why we did the poll.
All right. Just in the essence of time to just keep us on track. I believe there was one question in the chat you said,
Yeah.
Ricardo, I think you were asking, was there a difference between Medicare University and the Medicare Learning Network? Was that your question?
That's correct, Kim.
Yeah, there is. So Medicare University is really exactly what I showed you. The MLN is different. I could believe you can still access it through NGS if I'm not mistaken, but it is two separate things.
Yeah, the MLN
It's
Medicare Learning
notification.
Network is basically, you go in there and it's documentation that you read. You wouldn't be it's not that type of education. They do change requests would come through the Medicare Learning Network. Any regulatory changes, they do it on an educational type of a document versus Medicare University is learning. I think they even give Medicare CEUs. Well, they used to. I don't know if they do anymore.
Yeah, they do give certificates for some of them for Medicare University. And under the MLN, remember, you can sign up to receive that email, frequent emails, any updates to that. So, but yes, it is two separate things. All right, then we just want to move ahead to talk about some upcoming education that's coming our way. I think I skipped one. So on the 15th, we have an AI Unleashed Demystifying Artificial Intelligence for Business Success. Coming up in February, I actually am doing a 2-part webinar series on excellence in case management. And really would encourage, obviously, if you have new staff, it will be great if you're looking to train new staff in regards to case management. The format is really going to be a patient scenario that I'm taking this patient through admission, to a transfer to the hospital, to a resume, and to a discharge, and really integrating throughout the COPs, integrating throughout value-based purchasing. And it will be interactive. I think I think it should be very helpful for new staff. So we do bring that to your attention. It's kind of going about it in a different way, right? There's stuff out there about case management, but I'm really hoping for it to be more meaningful as it relates to what does this mean you're out in the home with the patient? What does this mean around patient-centered care? How do you work your interdisciplinary communication? How do you communicate in the best way to a patient that may have some health literacy challenges? So we're really excited about it. So we do want to draw your attention to that. And then there's another one, tackling job vacancies and turnover. And there's a 3-part series, February, March, and April, which is managing home health margins through clinical quality. This should be a great session too. Again, it's a 3-part series. So some exciting stuff coming up, and you can see all of these things on our webpage when you go on under events also and register.
Are you going to be offering Oasis, Blueprint for Oasis this year?
Yes.
We have.
Yeah.
Okay, great.
Yeah, I
In
think
the
that's being
fall.
offered in the fall, right? Yeah, in the
Mhm.
fall.
Oh,
And we
okay.
are,
Sometimes it's in April, so.
yeah, so it's in the fall, and we are looking
Okay.
at doing some targeted education around Oasis, like a smaller series, more information coming on that, really working around, helping staff understand how to answer the functionals, the GGs, et cetera. So that will be some smaller education, and that will be coming out in the future. But yes, some great stuff coming. So.
Oh, and for Kim's case management series, there's
CEUs.
nursing contact hours, and I have applied for physical therapy contact hours, and I can't imagine they would deny it. But we should find out about that. I would think within the next week. It does take them a bit to answer us back. Is there another question? No.
I guess not. So thanks so much, guys. This was a great meeting.
Oh, wait a minute, Kim. How would
say
you
what?
sign up for the webinar tomorrow? Oh, that's on our website, right?
Yep. The AI one,
Yeah.
I'm assuming?
Is the
Yeah,
link
it's on the website.
Okay.
Yep. It is.
On the calendar of events. Okay.
All right, guys. Thanks so much. It was great seeing all of you today. We will send the slides out to you after this presentation, and this was recorded. Great. Thanks so much.
Great.
Have a great day,
Bye.
guys.